Welcome to Session 2. In this presentation, we will discuss steps to solving a medical coding exam case study. But first, I want to introduce you to the team. First up, Mr. Sandeep. Mr. Sandeep coming to you live from Abu Dhabi. He is an AMCI co-lead instructor. Next up, Miss Eva coming to you live from the state of Florida. She's also a co-lead instructor and the intern coordinator. And finally, myself, Mrs. J. I'm the curriculum director at AMCI. Now, let's meet the AMCI interns. We have Miss Anubama, followed by Miss Carla, Miss Courtney, Miss Dolly, Miss Vivian, and Miss Melissa. Now that we're all acquainted, let's talk about the goals of the presentation. And we only have one. We will review scenarios from the urinary mail systems. Now let's talk about how to solve a multiple choice case study scenario the AMCI way for the board exam. This is how we do it. We teach you to highlight your key terms, and this key on the right tells you the colors that you should use and for what. A yellow highlighter should be used for diagnoses, all diagnoses, signs, and symptoms. The green will be for procedure. So if you have a green highlighter, the green will be used to highlight only procedures. And pink, these are inclusive or bundled items. All right? Once you've done your highlighting, you're going to have to document your inventory. That's your procedures, diagnoses, and select a primary code. Which diagnosis is primary, which procedure is primary. Then you're going to review all pertinent guidelines. And finally, the code that best matches your inventory list is often the correct code, or a code that is pertinent to a guideline. That will be your best code. All right. So here are some do nots. When you're highlighting, you can kind of get discombobulated. So we've compiled some things that you don't even have to highlight. Number 1, don't highlight things observed by the physician because you cannot code for them. Number 2, don't highlight closures. If a provider or surgeon is closing up a surgical site, there's no need to highlight it. However, if it involves a skin procedure or skin defect closure, you may definitely have to code that. So if it's closing a surgical site other than skin defects or wounds or lesions, you do not code it or highlight it. Also, you don't highlight bleed control, hemostasis, because that's pretty customary and it's bundled into the procedure code. You don't highlight drains, irrigation of the surgical site. Nope. And you don't highlight installation and removal of clamps and trocars because these are used to open up or maintain the surgical or operative site so the physician can view what they're doing, particularly if it's an open procedure. Also, you don't highlight dressings. And finally, you do not highlight surgical risks. Now that we've gotten that out of the way, I think you're ready to get started, and I'm going to hand it over to Mr. Sandeep. All right, Mr. Sandeep, take it away.
Okay, here we go. So as Miss Eva said, this is the third week sessions, and please do let us know how are you feeling so far about coding the long scenarios and how our sessions are helping you in tackling such challenges. Please let us know in the chat. And meanwhile, let me start the day. I think let me start the session with the male genitourinary system scenarios. And we are having our first scenario now. Let me welcome Miss Carla to read out the scenario for us. Miss Carla, please take it away.
All right, coders. Answer A. What are the CPT and ICD CM codes reported? Answer A. 51530, C67.0, C67.5, C61. Answer B. 52234, C67.0, C67.5, C61. Answer C. 52240, C67.0, C67.5, C61. Answer D. 52214, C67.0, C67.5, C61. Operative report. Preoperative diagnosis, gross hematuria. Postoperative diagnosis, bladder, prostrate tumor. Operation, transurethral resection bladder tumor, TURBT. Large, 5.3 centimeters. Anesthesia general. Findings, the patient had extensive involvement of the bladder with solid and edematous, appearing hemorrhagic tumor, completely replacing the trigone and extending into the bladder, neck, and prostatic tissue. The uteral orifices were not identifiable. Digital rectal examination revealed nodular film mass per rectum. Procedure description. The patient was placed on an operating room table in the supine position and general anesthesia was induced. He was then placed in a lithotomy position and prepped and draped appropriately. Cystoscopy was done, which showed evidence of the urethral trauma due to the traumatic removal of the Foley catheter. Patient stepped on a tubing and the catheter was pulled out. The bladder itself showed extensive clot retention. There was papillary and necrotic appearing nodular tissue mass extensively involving the trigone and the bladder neck and the prostrate area. The ureteral orifices were not identified. After consulting with the patient's wife and obtaining an adjustment to the consent, the tumor was resected from the trigone, bladder, neck, and prostate. Obvious edematous and hemorrhagic tissue was removed. Extensive electrocauterization was done for bleeding vessels. Several areas of necrotic appearing tissue were evacuated. Care was taken and avoided extending resection into the area of the external sphincter. Digital rectal examination revealed the firm nodular mass in the interior rectum. No impacted stool was identified. At the end of the procedure, hemostasis appeared good. Tissue chips were evacuated from the bladder. Foley catheter was inserted. Patient was taken to the recovery room in satisfactory condition. Addendum: the patient had a previous partial prostatectomy and had been found to have T2B NOMX prostate cancer. On the physical examination today and on the endoscopic exam, it was unclear as to whether the tumor mass was related to the bladder or recurrent prostate cancer. Pathology revealed bladder carcinoma in the trigone and bladder neck. and recurrent prostate cancer. Okay, coders, you all have 2.5 minutes. Let's get it. Let's code. Your time starts now.
That's time, coders. You know what? I've been observing, like, since we are into the third week of these group sessions, most of them have started putting their answers way before we finish the scenarios, reading out the scenarios. That's amazing job. And I think you have started to get the trick how to solve the scenarios, getting the keywords and all the stuffs. So keep it up. Good work, coders. And let's solve this one. The correct answer to the question is option C. Let's have our keywords. The post-operative diagnosis is a bladder prostate tumor. The operation performed transurethral resection of bladder tumor, large 5.3 centimeters. The patient was placed in a supine position. General anesthesia was given. Patient was placed in a lithotomy position. Then the cystoscopy was done, and then the tumor was resected from the trigone, bladder, neck, prostate. And the areas of necrotic appearing tissues were evacuated as well. The tissue chips were evacuated from the bladder, and the pathology revealed bladder carcinoma in the trigone, bladder neck, and a recurrent prostate cancer. So these are our procedure inventory. We are having transurethral resection of bladder tumor to RBT, which is the short form of a transurethral resection bladder tumor, large. The tumor size was around 5.3 centimeter in length. And diagnosis, we are having bladder carcinoma in the trigone, bladder neck, and recurrent prostate cancer. Let's begin the process of elimination. The option A 530, which is coding for a cystotomy for simple excision. I'm sorry, cystotomy for excision of bladder tumor. Yes, this is actually coding for excision of bladder tumor. But in this procedure, what happens is that the provider makes an incision into the bladder to remove the bladder tumor. So do you think, coders, this was an cystotomy procedure which performed? What do you think? Was this a cystotomy? Did the no, yeah, the surgeon didn't made any incisions to get into the bladder. This was a transurethral resection of bladder tumor, which means he has inserted, yes, TURBT, he has inserted a cystoscopy into the urethra, and with the help of the scope, he has removed the tumor. This was not a cystotomy position, so that eliminates option A. Now, option D, 52214. What is that coding for? This is coding for cystourethroskopy fulguration, including cryosurgery or laser surgery of trigon, bladder neck, prostatic fossa, urethra, and periurethral glands. Now, what this code does look tempting, seems like it's close to a procedure inventory, but if you have a forensic look into this particular procedure, the 52214 is not coding for a removal of bladder tumor. Yes, it was close. This is not coding for bladder tumor. In this procedure, actually the provider is using the cystoscope to pass through the urethra and into the bladder. He inspects the structures and he destroys the tissues, which is known as fulguration. He destroys the tissues on the bladder trigon, bladder neck, prostatic fossa, and urethra and or periurethral glands using the techniques such as electrocautery, cryosurgery, or a laser surgery. So he's destroying the tissues, not the bladder tumor. You got the difference, coders? A little bit being forensic will help. Yes. Let me just look into the chat. Okay, so that's where option D is wrong. This is coding for destruction of the tissues. Now let's look into option B and C, 52234, which is coding for cystourethroskopy with fulguration and or resection of small bladder polyps. This is a close one as well, but it is different from the option C, 52240, that 52240 is coding for large bladder tumors and 52234 is coding for small bladder tumors. So they have went further ahead and they have specified the centimeters of the small bladder tumor which has been removed. That is ranging from 0.5 up to 0.2 centimeter. So this is a place where our procedure inventory comes into play and help. You can see on the procedure inventory the size of the tumor which was removed was around 5.3 centimeter, and this doesn't fall under 0.5 centimeter to 2.0 centimeter. That helps us eliminate option B, and the one which exactly matches this particular size is option C, 52240, which is anything greater than 2.2 centimeter. That is large bladder tumors. They have specified that as well. So the correct answer is option C, 52240, C67.0, C67.5, and C61. How do you feel about the first scenario, coders? The first warm-up scenario? Good, easy, yes. Okay, well, you have said this is easy one. Let's go into the next one. I hope this will be also easy, but this is a little bit lengthy. Okay, as I said, select the code that best matches your inventory coders. Yeah, as I said, this looks a little bit lengthy, but don't get overwhelmed by the length of the operative summary. They are always long, but the answer is going to be easy one. So let's invite Miss Courtney. Miss Carla, thank you for reading that last scenario for us. Miss Courtney, this one is all yours.
All right, coders. So let's go through our answers first. So A, 49505, modifier 50, 54640, 54150, modifier 50 and 51, K 40.20, Q 53.23, and Z41.2. B, 49500, modifier 50, 54640, 54161, modifier 50 and 51, K40.20, Q53.23, Z41.2. C, 49505 with modifier 50, 54640, 54161, modifier 50 and 51, K40.20, Q53.23, Z41.2. D, 49505, modifier 50, 54650, 54161, modifier 50 and 51, K40.20, Q53.23, and Z41.2. Operative note, preoperative diagnosis, large right inguinal hernia, bilateral undescended testes. Postoperative diagnosis, bilateral inguinal hernias, undescended testes. Procedure performed, bilateral orchiopexy and bilateral inguinal hernia repairs, as well as circumcision on a 10-year-old patient. Estimated blood loss less than 5 milliliters. Complications, none. Description of procedure. After informed consent had been obtained previously and reviewed again in the preoperative area, the patient was brought back to the OR, placed supine, and general anesthesia was induced without problems. It was somewhat difficult to find an IV site because of the patient's body habitus. However, there were no complications with anesthesia. The patient was then appropriately padded and prepped and draped in sterile fashion. 0.25% Marcaine plane was used for bilateral inguinal blocks as well as injected in the sub-Q and the inguinal crease. I began on the right-hand side where he had an intermittent right inguinal bulge for several months. A scalpel was used to make a skin incision following the creases, and this was extended down through very generous subcutaneous fat and scarpous fascia to expose the external oblique aponeurosis. The external ring was identified, as was the ilioinguinal ligament. The ring was opened for a short distance. The testes was high in the scrotum and was brought through. The gubernaculum was then divided. A very large hernia sac was carefully opened and very carefully dissected down to the level of the internal ring. There did not appear to be abdominal contents within the hernia sac. It was then twisted and suture ligated at the base. The hernia sac was then sent to pathology. The testes was pink and viable. A dartos pouch was created and the testes brought through it. The neck of the pouch was tightened with a few interrupted sutures of 3-0 vicryl. Care was taken to make sure it did not twist the testicle and that the testes lay in a normal anatomical position. The scrotal incision was then closed with 5-0 plain gut. The external ring was recreated by approximating the aponeurosis of the external oblique. The underlying ilioinguinal nerve was identified and spared. Scarpus was approximated with 3-0 vicryl and the skin closed with 5-0 monocryl and a running subcuticular stitch. Stair strips and dressing were placed over this. On the left-hand side initially, his testes is felt to be almost non-palpable, but on exam under anesthesia, it again was within the high scrotum. With gentle pressure, I could make this essentially disappear into his abdomen, suggesting a large communicating hydrocele. I made the decision to proceed with inguinal hernia repair and exploration. Again, he had a Marcaine inguinal block and the skin was also anesthetized with 0.25% Marcaine. A matching incision was made at the scalpel following the skin creases. This was extended down through subcutaneous tissues and scarpus to expose the external oblique and the external ring. It was then twisted and suture ligated at the base with 3-0 vicryl. The hernia sac was also sent to pathology. At this point, there was sufficient length to easily bring the testes into the scrotum. A dartos pouch was created and the testes was brought into it, with care taken to make sure we did not twist the cord suture structures. The neck of the pouch was tightened with vicryl to recreate the ring. Again, care was taken to preserve the underlying ilioinguinal nerve. Scarpus was approximated, 3-0 vicryl as well, and the skin was closed with monocryl. Stair strips and dressing were placed over this as well. 0.25% Marcaine plane was then used for a penile block. A circumcising incision was made approximately 3 millimeters below the coronal margin and the penis partially degloved. Meticulous hemostasis was obtained with bovie cautery. The excess prepuce was trimmed. It was then discarded. The skin edges were approximated with 5-0 plain gut in a running fashion ×2. Hemostasis was excellent. The gland's head appeared normal. A dressing of conform and Vaseline gauze was applied. The patient was then extubated and sent to the recovery in stable condition. No complications. All right, coders, your time starts now.
I've given you a little bit over 2.5 minutes for this scenario because this was a lengthy one. But Chorus, I would show you how simple this long scenario is, and as we say after each and each scenario, score the option that best matches your inventory. Highlight your keywords. Know what the procedure is done. Just focus on those keywords that the procedure performed, how it is done. Okay, let's come to the scenario. Miss Courtney, I have to repeat this each after each session. You're just flawless with these operative summaries. I don't know how you do it, but you are doing it awesome job. And coders here is the post-operative diagnosis: bilateral inguinal hernias and undescended testes. Now you can see this is different from the post-operative pre-operative diagnosis. So something happened during the surgery that changed the diagnosis. Initially it was large right inguinal hernia, and later it was a bilateral inguinal hernia, and then we are having by undescended testis. And the procedure performed is bilateral orchiopexy. This is one procedure performed, and we are having bilateral inguinal hernia repairs as well. That's the second procedure performed, as well as a circumcision on a 10-year-old patient performed. So whenever you see a procedure such as inguinal hernia repairs or circumcision, always focus on the age. Always have a look at the age of the patient, because that might also change the procedure codes, because we are having age specific codes for these procedures. The patient was placed in a supine and general anesthesia was given. So the first procedure, doctor began on the right side, right inguinal bulge. On the right inguinal bulge, a skin incision was made. It was extended down to the scapa fascia. The hernia sac was carefully opened and very carefully dissected down to the level of internal ring, and a Datos pouch was created and the testis was brought through it. Now this is so far the procedures he performed on the right side. So this is all about a right inguinal hernia repair and right orchiopexy procedure performed. Are you following, coders? Just the procedures, two procedures performed on the right side. Okay, let's move on into the next portion. On the left side, initially his testis was found to be non-palpable, suggesting a large communicating hydrocele. Then inguinal hernia repair was performed. It was twisted and the Datos pouch was created and the testis was brought into it. So once again, so far the same procedure is repeated on the right side. I'm sorry, on the left side. Initially it was on the right side, hernia repair. Now it's on the left side, hernia repair, as well as left orchiopexy. Now let's move to the next procedure. A circumcising incision was made below the coronal margin, and the penis partially declawed. The excess purpose was trimmed and it was then discarded. So the third procedure now, the surgical circumcision, which is performed. So as most of you have said, the correct answer is going to be option C. Outstanding work, orders. Outstanding work. And now let's see how to solve the scenario. Before that, I will say what is an ear hernia. Hernia is one thing which majority of us would have faced in one or other stages of the life. So hernia is a gap in the muscular wall that allows the content inside the abdomen to protrude outwards. There are different types of hernias, but the most common hernias occur in the belly or the groin area. So what the surgeon does is, in our scenario, is an open hernia repair where an incision or a cut was made to the groin area, as you would have seen, and the hernia sac containing the bulge intestine was identified. The surgeon just pushes the hernia back into the abdomen and strengthens the abdominal wall with the stitches or using a synthetic mesh. The second procedure performed is orchiopexy, which is a surgery to move the undescended testicles back to the scrotum. So you can see the different types of hernias. There are umbilical hernias, inguinal hernias, femoral hernias. So that's all about the hernias. And let's come back to the coding portion. Procedure inventory. As I said, 3 procedures performed. Bilateral orthopexy, bilateral hernia repair, surgical circumcision is the 3 procedure performed. And the diagnosis inventory, we are having bilateral inguinal hernia, high scrotal testis, and circumcision. And these are our code options. We are having hernia repair, we are having orthopexy codes, and circumcision codes. Let's look into option B first. 4500. That's odd one out of all the 4. Let's see what it is coding for. 49500 is coding for repair of initial inguinal hernia aged 6 months to younger than 5 years with or without hydrocolectomy reducible. Why is this answer wrong, coders? Let me know in the chat. Why do you think 49500 is wrong? Option A. There you go. Yes. Beautiful, beautiful observation. Beautiful observation. Because this is coding for a younger than 5. And what was the age of our patient? It is 10-year-old patient. That's why I said when you see circumcision or in a hernia repair, always have a look into the age of the patient as well, because that will help us narrow down the options. Correct, coders. That's eliminate option B. It saved a lot of time. We didn't went to the second code or the third code. We got that this is a wrong answer from the first code itself. Let's look at the next one, 49505, which is coding for the repair of initial inguinal hernia, age 5 years or older, reducible. Now this is a correct one. Now let's have a look into the next code, 45650, which is coding for orchiopexy abdominal approach for intra-abdominal testis. So what do you think, which approach was used? It was not an abdominal approach. An inguinal hernia was also repaired at the same time. So doctor made incision through the inguinal region, and that was an inguinal approach. You can find over here a bilateral inguinal blocks were administered in addition, so that he can do the incision through the inguinal region. So this was not an an abdominal approach. That eliminates option D as well. Now let's have a look into option A for a 9505. I've seen many of them saying option A in the first initially in the first 5 or 10 seconds. I'm not sure. Let's see what 49505 is the correct answer. The second code is coding for 54640, which is orchiopexy inguinal or scrotal approach. Now this is one that matches our procedure note. Yes, orchiopexy was performed by an inguinal approach. The third code, which is 54150. 54150 is coding for a circumcision using the clamp or other device with a regional dorsal penile block or a regional block, so a ring block. So clamp there was no clamp used for the circumcision. If you can read through those lines, circumcising incision was made below the coronal margin, and the penis was partially declawed. There was no clamp used. So that help us eliminate option A as well. And the correct answer would be option C. And then let's look into the last option, 54161, which is circumcision, surgical excision other than clamp device, or dorsal slit older than 28 days of age. So that was a surgical circumcision performed as said in our procedure inventory, and option C is the correct one. How do you feel about this scenario? Okay, so I've seen everyone got overwhelmed or intimidated by the scenario in the initial place. So was that so tough? Do you think it was tough? Mhm. Yeah, so as I said, focus on the keywords. Don't get intimidated when you see such a long scenarios. Focus on the keywords. What's the procedure performed? What's the technique used? And if you can get any key things from that procedure note, that will help you eliminate the options as well. And just match the procedure inventory with your answers.
Thank you, Mr. Sandeep, for those AMCI amazing and awesome explanations. Miss Eva, for being the orchestrator and conductor of the best interns on the planet. Yes, I said it. Miss Melissa, Anubama, Courtney, Carla, let's get it, let's code, Dolly, and Miss Vivian. And let's not forget our interns in the chat, led by Miss Biji. And you, the students, you all are simply the best, and we appreciate you. And we will see you next time for more great scenarios. You don't want to miss it. And thank you for participating in the AMCI Medical Coding course. Until next time.